Dr. Daver, what are the different subtypes of AML, and are various subtypes more prevalent in certain demographics?
The main way we have classified AML has actually been changing. So, when we talk about subtypes, there are actually two different classification systems, the WHO and the ICC or ELN classification systems. Traditionally, we have been using the ELN for prognostic classification of AML. This divides patients into three major buckets, what we call the favorable, intermediate, and adverse. And these are based on the underlying chromosome cytogenetic abnormalities and molecular or next generation sequencing profile of the patients. In general, in AML, there has actually been limited data and publications regarding the demographic distribution, whether it's regional or racial or cultural. One of the things that we do know, for example, in acute lymphoblastic leukemia, is that in the Hispanic population, there seems to be higher frequency of things like Philadelphia positive ALL, but in the AML population, there actually does not seem to be, at least based on published data, huge differences in the molecular or cytogenetic presentation. We have seen in some data from different countries that there may be a difference in the prevalence of mutations across different regions. For example, in Japan, we do see that the incidence of FLT3 and NPM1 appears to be lower than what has been reported in the United States. Also, we see in Europe and United States, the incidency of these mutations, FLT3 NPM1, is similar. And then we are seeing in some of the larger academic centers in the US, there is an enrichment of referral of patients with TP53, which is a very adverse and most difficult to treat mutation. And a lot of that, we think, is because patients with solid tumors and with other hematological malignancies are surviving longer with the CAR T therapies, immunotherapies. And because of this, over time, they have a risk of developing secondary AML, which is enriched for TP53 mutation. So we do see over the last 2 decades that from TP53, which used to be about 5 to 10%, is now up to 20 to 25% of AML and growing in proportion because of better survival in solid tumors and lymphomas. The activation tip related to this question is that in general, there don't seem to be huge discrepancies based on geography and race and region in the molecular cytogenetics. However, we do see differences in patients who have received prior chemotherapy, radiation therapy, immunotherapy for other solid tumors and lymphomas. These patients, when they transform to what we call secondary AML or MDS, seem to have a higher predilection for certain high-risk mutations such as TP53, and these are best treated with ongoing frontline clinical trials at large academic centers.